I would argue that fatty acid oxidation disorders or organic acidemias are. But they fit reasonably well. What's different for these conditions? Well, the timing for therapies and what therapies you do. Many of these disorders are treated with enzyme replacement therapy or bone marrow transplant. So you've upped ante quite a bit in terms of complexity of therapy and in some cases cost. The therapies, depending on the nature of the disorder, are varyingly effective. While I know you experience the same thing, so the therapies are varying and affecting in your conditions, I think they're a little clearer because we have more experience. The cost of therapies, there's a big differential here. For many of you, although the burden, for example, if you have a special formula, is high, it is nothing compared to the hundreds of thousands of dollars per year that families who have enzyme replacement therapy costs would have. And the timing of onset for manifestation of the conditions is quite different. These aren't kids that are going to get sick as neonates and have catastrophic events. It's going to be a slow progress. So again, talking about the timing and the clock, is this the right kind of target we should have? So here's some variations on our paradigm. The original intent was to add conditions with demonstrable effects of early treatment. And for these new disorders, some of these yes, and some of them no. We don't know that they need early treatment, they just need to be treated preemptively. And a good example of that is an additional disorder that was added called X-linked adrenoleukodystrophy, where boys at about 5 to 6 years of age will develop a rapid neurodegenerative process which you can stop by bone marrow transplant. But you don't do the transplant when they're a baby. You don't do it until they start to show the symptoms at age 5 or 6. Adults with this disorder develop adrenal insufficiency, and it's a magnificent thing to know they have it. But it doesn't need newborn screening to do that. If you were going to test it, it might be better tested at a different time. But it was fit into this category because of the way that none of these things are detectable without some sort of knowledge to test for it. And the only place we do that in our healthcare system is in the newborn period. And their argument was very cogent, and it was added with a lot of enthusiasm. But it doesn't fit the original paradigm very well. All right. Some of the old ones don't fit this so well either. I've already told you that, so I'm not trying to quibble too much about it. So adding conditions with effective treatments. I think particularly when you go off the federal guidelines and do this by legislative mandate, disorders get added that don't have effective treatment. And that's a problem. But some of the disorders we've added as part of our newborn screening panel originally don't have particularly effective treatments either. We palliate and improve things, but I'm not sure that we make a long-term difference. All right, so what's the big difference between these things? What I regard as being that 500-pound gorilla is the impact of adult onset versions of these disorders and the corollary that goes with that, the timing for interventions. So if you have a disorder that has two forms, an infantile form that you can screen for, but you'll also pick up all the adults who would have symptoms when they're 50, oh my, what do you do with those people who aren't going to have symptoms till they're 50? Who's going to keep track of all that? Oh my, is it the Department of Health? Is it their own doctor? Is it them? Well, I would argue that many people won't realize that they had that test done when they were a baby, and that knowledge will not be sustained. So this is a big problem in public health right now. What do we do with late onset versions of the conditions we screen for very righteously in the newborn period? All right, some additional, remember, one of the things that happens, and I mentioned this with the secondary conditions, the MS testing, the tandem mass spectrometry, brought a lot of tag-along disorders because of the metabolite studies. When we added severe combined immunodeficiency, the target was severe X-linked SCID. It's a very devastating disease that requires very early bone marrow transplant, which is life-saving. But there are other disorders that have milder versions of this that newborn screening isn't a particularly effective tool, but you get that information anyway. So what do you do with information that tags along? And this is true in the new edition of the disorders. The X-linked adrenoleukodystrophy I mentioned, well, when I talked to you yesterday, I said, don't worry, it's all autosomal recessive, that's all you need to know. But if you had a child with adrenoleukodystrophy, that would not be your only problem. That one runs in families where boys have the disorder and moms are the carriers, so there's a whole family discovered when you screen a baby. So you have a whole new set of people you're taking care of when that newborn screening takes. So, and one of the questions we've had to ask ourselves, I mentioned, are really those adult onset variants sort of secondary targets? They probably really are. They're still important to know about. We're not going to do this. We can't push the elephant back in. These things are on our recommended uniform screening panel, so we, as a community of citizens, need to be aware and consider what the consequences of these things are. So there's some other practical limits. Infrastructure. When you add a new test, that means the Department of Health has to figure out how to do the test, and then they have to implement it in their own system. And nobody takes care of that very much. And so there are added consequences with those long-term things. Whose job is it to follow them? Is it the Department of Health? There's not an answer for that. All right, so if we just, we don't really have a way to do that. So could we change the target? Is there a way we could filter the information so we really went after the newborn screening disorders? Could we avoid having people carry all their lives the consequences of knowing that at 50 they're going to have a problem? We probably could if we think about this, but right now we haven't done this. And there are all sorts of issues about discrimination and sort of a sword hanging over your head that are difficult. So we'll keep working on that. I'm not going to go through this piece too much, the practical limits of people, because Mark just told you about this. This is a really, really big problem, and you've heard enough about that. What about the costs of therapy? Nobody really thinks about this. For the new disorders, some of you may have seen, because it comes across in listservs that many of you follow, that a very specific form of spinal muscular atrophy, sometimes referred to as Wernicke-Hoffmann disease or SMA, has been added to the recommended uniform screening panel. This is because of a very novel therapy that takes this disorder from being one that babies will die in the first year to 2 of life. Absolutely die. There's no treatment before this, to one where the babies walk and talk and, at least to the age that they've gotten, have not perfect, but very good development, physically and otherwise. So it's a fundamental, profound treatment. And so it was added, but this particular treatment costs $125,000 for the first spinal injection you have to have, and you have to have a series of 4 or 5 of them the first year and then continuing. So how much is too much? I don't know the answer to that. How much is a life worth? I don't know the answer to that. Do those families deserve that treatment? 100% they deserve it. How do we account for that cost? I don't know. So how much is too much? Do treatments do enough when we do these things? And how are we going to know that? Because we haven't done a particular, I'm trying to be a bit downer, Debbie Downer here, but we owe ourselves the opportunity to have better long-term follow-up for all of these things. So one of the other things I'll just mention as we're coming to the end of this is the philosophical limits. Is newborn screening the right tool for all of these things? And since it's mandated, we have to do it. How do we choose to impose that on others? So, with regard to newborn screening being the tool for the job, is this always the way to do it with the state mandate? Are there other regulatory strategies? For point of health things, point of care things like hearing and heart, maybe we should have handled those by rules for the hospitals, not rules of state mandated newborn screening, but that's what was done. What's efficacious treatment, and what benefits of treatment are justifiable to mandate screening? I don't know the answer to these things, so I'm going to just let you think about those dancing pills. When we add based on recommendation with hardcore evidence review, I think most of us feel justified that we've made a careful and scientific decision. But when disorders are added because of legislative responses to constituents, they often have a lack of evidence without criteria, and there's no way not to have the state do it when it's mandated by legislation. So we're caught in the middle there. And people are afraid to stand up in a legislative setting like that and saying, why are you newborn screening for this? because it makes everybody look at you like you're the most evil person in the world. So what's the goal of newborn screening? Where were we going in the first place? Is our definition of a primary target what we want as a community? I actually think it's a good definition, but I think all of us as a community of citizens, of rare disease advocates, as parents, as people who care, should really be clear on that. And if our definition isn't right, what should be the definition and who decides? So we'll be interested to see how this gets decided by the Secretary's Committee. Finally, there's the impact of new technologies. Sometimes the newborn screening is a risk assessment. It tells you somebody has a probability of disease. Well, I'm sorry, when you do a DNA test and show someone has 2 SMN1 deletions, that's a diagnosis, not a screen. That's a definitive diagnosis. And when does this become invasive instead of helpful? That's also a problem some of you may have experienced. And are all of these things that we should do in newborns? And when should we be thinking about doing it in other targets? So I presented you some philosophic and practical concerns about newborn screening despite my desire to advance it. I love all of it, and I know we will continue to advance newborn screening. I particularly want you to know about my mom, who was my inspiration. My mother was a metabolic disease specialist at the University of Cincinnati. She was among the early people to assist in treatment of PKU. When I was a 16-year-old, I used to make mixed diets for the kids with PKU and cystic fibrosis, and I used to run phenylalanine, so this is kind of in my blood. And if you didn't know my mom, I wish you could. She would be very proud of this group. This was the whole concept of treatment of inborn errors of metabolism was a fundamental to her life, so I'd like you to acknowledge her and see that she's there. So, thank you.